We are seeing more and more cerclage insertions done in our OR. And so the patient could be um, anywhere really. She could be on prenatal, or she could be coming in through assessment and then going to an SRMC room for a few hours and then going home from there. So the purpose of a cervical cerclage is to treat a issue called cervical insufficiency. So there's something wrong with the cervix, that it is thinning and opening much too early, whether that's from a structural defect, that something this person was born with, or something that's happened to her, so a functional defect. And it usually presents as painless progressive dilatation, so the patient doesn't even know about it. What's the result of this cervical insufficiency? Preterm birth is the number one, often of a non-viable fetus, so we risk losing the pregnancy altogether. Prolapse of the membranes through the cervix, which could then possibly lead to PPROM. And then extremely preterm birth is an adverse event as well. So the claim is that it affects up to 1% of obstetrical populations. Causes, if a person has had several second trimester miscarriages, whether that be a spontaneous miscarriage and the contents of the uterus emptied on their own, or if she's had a spontaneous miscarriage unintentionally and she required D&Cs in order to remove the products of conception. Any D&C procedure is scraping the lining of the uterus, possibly damaging the cervix, so it is surgery. It is prior uterine surgery, and that carries with it risk for future pregnancies. Having had a previous cone biopsy or a LEEP procedure, or any type of pregnancy termination, whether that was done in an approved healthcare facility or not, developing world or developed world, all of that can cause damage to the cervix. And then many of these cases are idiopathic, meaning we don't know why they happen. For some reason, the cervix is shortening and opening. The number one cause overwhelmingly is an intraamniotic infection. And this could be something that the patient doesn't know about. She's not having any leakage her vagina, but yet the fluid or the membranes or the uterus itself could have an infection in it. Other structural defects that the patient may have been born with would be a uterine anomaly, such as a septum, bicornate uterus, maybe two cervixes, two uteruses, and then there's maternal connective tissue disease that is just emerging as one of the main causes. Like I said, in lots of cases, there's no identified reason. So this is a surgical procedure. It is the insertion of a piece of material that is used to sew the cervix shut. And that does sustain the pregnancy. There are several different methods. There's the McDonald suture, and it's just the method in which the suture is tied. There's the Sherrodker suture. So you see a picture here of the physician taking a sponge stick, pulling the cervix closer to the introitus, stitching it shut and putting it back. So it does cause some stress on the cervix, and we'll talk about the risks and overcoming those risks. So in this case, the Sherrodker suture, and whatever suture method is used, it doesn't really matter which method is used, but what does need to be documented is the location of the knot. And it's usually put at 12 o'clock so that if the stitch had to be cut in an emergency situation, they would know where to cut the knot. So there are elective cerclages done sometimes a lot earlier than we do here. So that would be done electively as an outpatient at Saskatoon City Hospital. This would be for a patient that has had a history of cervical incompetence, history of second trimester losses, that would be done electively. We generally see the urgent emergent cases on our unit. So the patient has gone in for what she thinks is a routine checkup, and they've done a transvaginal ultrasound, and they have seen on the transvaginal ultrasound that the cervix is thinning, possibly opening. So then the decision needs to be made as what we're going to do. So the first thing that needs to be done is we have to assess the patient for all types of infections. So is there a vaginal yeast infection or BV? Is there a urinary tract infection, any kind of STIs? And then finally, the patient might go for an amniocentesis, and the fluid, the amniotic fluid, is tested for infection first. Because if there is infection in the amniotic fluid, it is not a very good prognosis. The fact is that if there is infection in there, it is going to eventually hurt the baby and eventually cause the mother to go septic if we don't act. So when the surgery is elective, there's an 85 to 95% success rate. When it's emergent, meaning the cervix has already started to thin and open, it's a 40% success rate, but it's not very high, but it's better than zero. It's better than doing nothing for most people. And I mean, the risk of preterm birth is greater when a person's carrying twins or other multiples, but they have not found that doing a cerclage just for the twins indication has not shown benefit in prolonging the pregnancy and preventing preterm birth for these babies. There would have to be other factors as well. So at this time, we're not doing elective cerclages just because of a twins or triplets or other multiple diagnosis. So what are the risks of cerclage insertion? So the first risk when the procedure is being performed is accidentally rupturing the membranes inadvertently, because we're working around in that area and there's always a risk that the membranes could rupture. So that would probably be number one. Number two would probably be risk of preterm labor, because we are disrupting the cervix. And anytime we disrupt the cervix, whether that be with a vag exam or grabbing it with a sponge stick and stitching it closed, there is a risk that that cervix will want to thin and open even more. Then there's the risk of inserting a foreign body into the body, and the risk that goes with that is infection leading to sepsis. And then after all that is said and done, and if we pass those hurdles, if we overcome them, then there's the risk of scarring on the cervix, and that the cervix won't open in labor when we want it to. There is a risk of the cervix tearing through the stitch or not through the stitch at delivery, and then risk of hemorrhage, because if the cervix wants to thin and open with the stitch in place, it could tear the cervix, and that is a huge risk of hemorrhage because the cervix is very vascular. So what's the procedure on our unit? The patient is admitted either to prenatal or directly to an SRMC room, really wherever there's space. Continuous EFM only if the fetus is viable. If he is not viable, we would do a 1-minute auscultation. Anesthesia is usually consulted, and there's a plan made for the OR. It's generally done using a spinal. And procedure takes maybe half an hour. She needs to be in recovery room for 45 minutes to an hour. And then after the procedure is finished, then the physician will provide direction on whether the patient's going to be going home maybe later today or tomorrow, making plans for the post-operative recovery period. So nursing care for this patient, when she comes back from recovery room, we really do need to rule out preterm labor if the body has kicked into preterm labor because of the disruption of the cervix or just having the surgery. So we really do need to put our hand on the uterus and palpate for any kind of uterine activity for a period of 10 minutes. The other reason is because she has a spinal on board, and while it is wearing off, it might be covering up any sort of cramping or back discomfort or vaginal pressure that she may be feeling. We're going to do our vital signs and fetal heart rate as ordered, and then your patient teaching includes, it's somewhat normal to have some brown discharge. today, the next day, but then it should go away. If it's bright red or if it's accompanied by mucus, you should come in to be assessed. If you have a gush of fluid, you should come in to be assessed. If you have contractions, you should come in. Contractions could look like cramping, low pelvic pressure, backache, because preterm labor doesn't act like term labor. And then we want to teach her about signs and symptoms of infection. So if she has a fever, chills, foul vaginal odor, foul vaginal discharge, nausea or vomiting, she should for sure come in. This might be one of the only times on our unit you see a patient on a limited amount of bed rest. If they're just at the cusp of viability, 23 and 5, 23 and 6. Maybe we do put her on bed rest for a couple days just to get us to viability, maybe give a couple days for the betamethasone to work. May or may not be with bathroom privileges. You may see the patient with a Foley catheter in situ. You may see the patient set in a little bit of Trendelenburg to try and keep the membranes away from the cervical opening. If your patient has had bed rest prescribed, please put on pneumatic compression stockings for her and teach her to do ankle exercises because we want to minimize the risk of a clot forming. There is a discharge care plan you can print off of ISP that has all the teaching which I've just described. So the patient will be discharged home. These are the instructions that I've just discussed. So diet is tolerated, avoid constipation, bath and shower per usual. Come in if you have any of these symptoms. As well, the physician might prescribe vaginal rest, which would be no sexual intercourse, nothing in the vagina for sure until you follow up with your doctor, but it might be prescribed for the remainder of the pregnancy. So when do we take the cerclage out? It is removed electively between 36 to 38 weeks, depending on the situation. If the patient comes in ruptured, we might cut the stitch. If the patient is cramping or bleeding, contracting, we for sure will cut the stitch and then deal with the implications of preterm birth at that time.